So thank you very much. Assalamu alaikum and a good afternoon to everybody. I would like to begin by thanking Amal and especially Dr. Ghassan for giving me this opportunity to speak to this amazing conference. It has been wonderful lectures and really good debates, and I'm here to add to another one. I'm Dr. Sadia Malick. I'm a consultant obstetrician and gynecologist at Cornish Hospital, and I'm also the lead for the office gynecology, ambulatory gynecology unit that we have recently set up in the first one in Saha in Abu Dhabi. So I have been asked to present about abnormal uterine bleeding and whether we want to give hormones or whether we want to do surgery. Now, there have been extremely heavyweight, eminent speakers before me who have actually dealt with the topic and given their advice about hormonal and surgical management. And also, Dr. Ghassan did an amazing keynote lecture on it. So I just have two takes on this. I will present what I actually do with my skills in this area, what I do in my practice, and also what I have tried to do is standardize certain managements for our gynecologists sitting in the gynecology clinics facing with abnormal uterine bleeding day in and day out. So we use the evidence to help them do a standardized management, our residents, our juniors, our medical students. So that would be my take on this talk today. So beginning from what is abnormal uterine bleeding, really, I really want to let people call it a set of symptoms and not to make it into a disorder, a disease, or a big problem for the patients walking in. That would be my definition of abnormal uterine bleeding, that it's just some symptoms that the women have. Yes, it has a huge impact, as we have learned through this conference, rarely life-threatening, but definitely life-altering. Then I'm very pleased that we have moved on from the terminologies that we used to use, and now we have better terminologies. We started talking about it way back in 2007, and then FIGO joined in, and it took them 10 years to get there, but they gave us this very good publication in which they have divided it into the structural and non-structural causes of AUB, and I think that is very helpful, and my talk will rotate around this publication. The best thing that they have done is that, as we discussed, that they've given us a normality. So when a patient walks in saying, doctor, I've got problems with my periods, I'm still the old-fashioned gynecologist which asks for a period diary. And when it fits between the 24 and 38-day cycle, we can reassure them that actually you don't have a problem. I mean, 38 days is, my God, 1 month and 10 days almost, so 1 month and 8 days. So we can reassure them that that is normal. And if they bleed up to 8 days, then according to the evidence, that is also fine. And the flow of the patient is also being left for the patient to define. And if she's happy with it and she copes with it, well, that is normal again. So make more time to make a patient normal than abnormal. I would like to mention to label it into acute or chronic, because when it's an acute bleeding, it's for the clinician to say that there is sufficient quantity of problem to require immediate intervention to minimize or prevent further blood loss. But when it is chronic, then we have to say that we are addressing a chronic AUB, which is defined as uterine bleeding in abnormal in duration, volume, frequency, and has been present for the preceding 6 months. And now the patient is presenting on as acute on chronic. And what is the duration, volume, frequency has already been defined by FIGO. As I said, I love this slide, which I also share with my patients. Now, coming back to how we are going to tackle this patient, how we are going to help her when she comes, go back to the age-old, listening to the woman and giving her what she actually came for. So I always say, when somebody comes in and say my periods are abnormal, you have to go into the fact as to why is she actually there. And majority of my patients are really frustrated with their period cycle because they are unable to conceive. They have got these massive apps and gadgets on their phones trying to find their ovulation and putting these numbers on their phone, trying to say they've got irregular cycles, that's why they're not catching their ovulation, and that's why they're not getting pregnant. This is where you step back and you change the hat of the discussion from an abnormal uterine bleeding to a discussion of fertility. putting it into either primary fertility problem or secondary fertility problem. And once you say that, you will know that you are dealing with only one half of the problem. The other half is sitting at home, sending their wives to actually get their abnormal uterine bleeding sorted. We know that the male factor is solely responsible in about 20% of infertile couple, and it is a contributory factor in another 30 to 40% of the couples. We have to address that before we give nortestosterones and dydrogesterones to these patients to regulate their cycle. And when you look at the flip side of the coin, is a patient coming in who is complaining about her periods but actually does not wish to conceive. I always see it as a cry for help, but somebody dealing with 2 or 3 children sitting in front of this modern day learning in front of Zoom. She's got one baby on the breast, 2 children to teach, and she's really, really anxious that she's going to get pregnant on all of this. And there is a lack of patients coming in wanting to discuss contraception, because there's so much negative connotations to contraception that sometimes you feel that they are also doing the same thing. They don't want to get pregnant and they're hiding behind different apps and gadgets trying to find their fertility period, avoiding it. All you need to do is give them a good contraception and the problem of AUB is over. Similarly, sexually transmitted diseases, I feel it is very important that we highlight that we know that any kind of sexually transmitted diseases can lead to uterine infection, leading to abnormal uterine bleeding. And if a good history suggests that is the case, we have to go ahead and treat that. And that is what you would need for your abnormal uterine bleeding. Is another interesting one. So if they have abnormal bleeding and they have got heavy periods, as mentioned, that NICE guidelines suggest that we leave the patient to describe how heavy is heavy. FIGO is also telling us the same thing. So excessive menstrual blood loss, which interferes with the woman's physical, social, and emotional or material quality of life. But then we get to know is that what is bothersome, and a woman's ability to cope is sometimes so much that you would really need a hematologist to send a patient to a gynecologist saying, Dr. Malick, have a look at her. I've given her 10 times IV doses of iron, but she doesn't seem to have heavy periods. But when you look at it, she actually has heavy periods. So you have to sometimes address that issue with the patient. Coming back to the FIGO classification, I believe that it is really good in telling us about the structural and the non-structural problems so we can address them. So looking at the structural pathology, of course, FIGO says that these are those which can be imaged and can be defined histopathologically. So you have your polyps, your adenomyosis, your leiomyomas, and of course your malignancies. If you can see it, then most likely you would want to remove it. So that takes away the debate as to what you want to do with if you have a structural problem. While the coincide remains the non-structural ones where you will only need a detailed history, of physical examination, and some lab tests to define it. Foxy has put in all the management that you would need in one slide, and this is, I find, very helpful when you want to standardize management. But what would I do? If there is one polyp, you do a diagnostic hysteroscopy, you find the polyp, you remove the polyp, and if she wants to have a baby, she can go and have one. But if there are multiple polyps, and there is obesity, diabetes, other causes which increase development of polyps, and she has completed her family, I honestly believe that we as gynecologists don't do the 1, 2, 3, what I call in polyp management. So you remove the polyp in whatever you want to do, true clears, MyoSures, whatever you wish, but then go ahead and put in a Mirena, do an endometrial ablation if she has completed her family. And if she hasn't completed a family, to ask her to go and complete it, because that will then stop her from coming back to you again and again. I really believe that we don't use Mirenas and endometrial ablations as much as we should be using. With new ambulatory gynecology settings where you have got balloon catheters of 3 millimeters and your whole procedure is finished in less than 3 minutes, I believe we need to do this more often. I published way back in 2011 with Justin Clark. This was our first group ever to say to the world that we can do office gynecology under local anesthesia only. We did a 5-year follow-up of all these patients at that time. And we have moved on from the versoscope that we used at that time. I currently use this amazing device in my ambulatory gynecology unit in Cornish Hospital. And we have also moved on from those horrible, dreary office gynecology settings of dark and gray rooms to a much better patient-friendly rooms like this, where you can do a quick procedure and make a patient also happy while she is there. Moving on to adenomyosis. Again, you have had heavyweights who have told you how to manage adenomyosis. My take to that is that I honestly believe, and as my eminent colleagues have mentioned, it remains largely underdiagnosed. It is so easy to comment on those large ovarian cysts with endometriosis, that submucosal fibroid, that large pedunculated fibroid, and you want to go and manage it. But even in these cases, you will see patients still have adenomyosis, which was overlooked. So that is why when we manage the other conditions, patients are still not happy and they still have their period pain, they still have abnormal bleeding. So I really feel as gynecologists that we should be knowing the scan findings ourselves. We should be looking for these further adenomyosis more so than we do at present. There is a treatment algorithm for me. If they finish the family, Mirena, best for them. If even if they want a baby, you can, and they're young enough, you can put a Mirena for a year or so, even give the gonadotropins for some time, and then they can go back to the fertility. And of course, if they do not require fertility, again, Mirena comes as for me as a simple first line management. My colleagues have discussed lots of hormonal treatment, which I would leave it to you as to whatever you find is helpful for your patient. I've started giving the Dinogest, which I like also, if I'm not putting the Mirena inside, or you can give the Mirena and Dinogest. I will refer to Professor Momar's talk in which he is prescribing so many medical managements for endometriosis. I believe all the medical management for endometriosis should be offered to women with adenomyosis. And if you are very, very mindful of the start of adenomyosis, then you will be able to see it at the interface of endometrium, myometrium. And at that time, I believe endometrial ablation and the many techniques of TCREs would be very helpful for women who have completed that family. But over here, I would also want to mention interventional radiology. For that, you should have a great team of interventional radiologists who have got experience with uterine artery embolization for adenomyosis. And I'm very blessed in Abu Dhabi that I have that team, and we have used that with very good results. There are a lot of publications out there which will reassure you that that is a good management for adenomyosis. And as I mentioned, any medical management for adenomyosis can be used for adenomyosis also. And there are very good papers out there and very recent papers which are giving you the confidence of going ahead that extra mile, which we are not used to giving in our gynecology clinics to adenomyosis patients. When we mention hysterectomy for adenomyosis, I always say I put a big X on it because I really say that people are doing adenomyomectomies and not hysterectomies for adenomyosis. So I think if you are only planning a hysterectomy for adenomyosis, you haven't gone that extra mile. Is my take on hysterectomy for adenomyosis. Regarding leiomyomas, you have had a very good discussions on different types and what we should do. For me, again, first lines are non-hormonal, and if you want to give Mirenas for less than 5 centimeter, works like a dream. You can give the GnRH analogs along with, I like triptorelin and Zoladex, uterine artery embolizations, and different kind of hysteroscopic treatment, and of course, endometrial ablation post removal of some mucous fibroids. We have got this very good classification by FIGO. Once we do our diagnosis properly, I really believe in transvaginal scans can help you if you do them yourselves to identify and give it a classification to manage, to discuss your management. For me, I remove the submucous fibroid and do the 1, 2, 3 of it also. If they have completed the family, put in a Mirena, do an ablation. We don't want them in this pandemic to keep coming back to you for the same problem again and again. Regarding hysterectomy for myomas, I think, and has been mentioned before, that there are some amazing people everywhere around you who are experts in your myomas. And even before I plan a hysterectomy, I would always take a second opinion for people doing hysterectomies or myomectomies. And there is absolutely no harm in discussing with them before you actually discuss hysterectomies for fibroids. Um, Coming to the functional part of the classification, in which when we have got abnormal uterine bleeding due to non-structural abnormalities, we have the list of coagulopathies, ovulatory dysfunction, endometrial causes, iatrogenic, and not otherwise classified when you don't know what is going on. Um, when we talk about hormonal treatment, we have got these 6, 7 hormones that we can give. And the audience that I'm talking to is very comfortable in giving one or the other in all these different types of treatments. And you have had great lectures in the use of these hormones. Um, but I would just like to highlight the first thing would be that coagulopathies. Now, if you look at the prevalence, the evidence is suggesting that 3% of women presenting with heavy menstrual bleeding actually would be hiding a coagulopathy. Now, if I just count my practice, that would mean at least 40 to 50 women that I will see in a whole year might be having von Willebrand's disease, greater dysfunction, factor 11, factor 10. So, and then there will be patients who are taking anticoagulants. Again, for me, it is very important, just simple screening with a simple history taking. I have this on my phone. I ask them these questions. If the answer is yes, they are testing positive to this simple screening tool, where you refer them to the hematologist before you keep on treating them for the general things that we do as gynecologists. And this is extremely important and a simple way for helping your patients. Um, Regarding the ovulatory dysfunction, the etiology of that, well, we know that it occurs in the absence of ovulation and formation of corpus luteum. There is lack of progesterone and the unopposed secretion of estrogen, leading to a continual endometrial proliferation without progesterone withdrawal induced shedding. Okay, so when the bleeding is unpredictable and sometimes interspersed with episodes of amenorrhea, that is your AUBO. If you have come to that decision, for me, this is the list which is most important in terms of the cause of ovulatory dysfunction. I am going to keep stress and anxiety, obesity, anorexia, weight loss, extreme exercise, your adolescence, and your perimenopausal to most likely suffer from ovulatory dysfunction. Now, nowhere in this list would you think that noradrenaline or dydrogesterones would be your definitive treatment. It really needs a very, very empathic and sympathetic approach by a gynecologist to these patients in order to help them to the root cause of their issue, and then help them how to help with the AUB in these patients. But so many times for us, just putting PCOS, thyroid disorders, hyperprolactinemia, it's an easy diagnosis with some easy tests, and we put the patient on this path. While the screen on your left-hand side would, I think, at least in my practice, a majority of my patients walking in with this problem. In the iatrogenic causes are the ones that we have actually caused them to have the bleeding, but we need a good history to tell us that they are using certain drugs, including heparins and anticoagulants and steroid hormones, or the coil, the notorious Implanon, that is giving them the AUB, and we need to rectify that accordingly. I like this diagram very much from the FOGC, that if it is not AUBO or I or C, then it leads to the E, which is the AUB because of the endometrial reasons. This one has been classified by FIGO as a diagnosis of exclusion. So they say that it is determined by exclusion of other identified abnormalities in women of reproductive age who seem to have a normal ovulatory function. I really think, of course, we can help the women with medical or treat the infection of the endometrium, and over here also my trusted endometrial ablation and uterine artery embolization would be helpful. a very clear and I should say thorough hysteroscopy would really help you to identify those areas in the endometrium that might be missed generally. If, as I said, the eyes don't see what the brain doesn't know, but you will be able to find problems with the endometrium, which you can then address after the hysteroscopy. The not yet defined classification comes in of AUB, where you haven't really put your finger on as to what is bothering the woman. But in this chart also, you will see that all the evidence uh, uh, points out to, again, using either the levonorgestrel hormone, the Mirena, or the GnRH analog. Uterine artery embolization also comes up over here because you may be missing some AV malformations which you haven't been able to find out. And hysterectomy really remains the last resort for this group also. For hormonal, we know that we use the short-acting oral contraception device medicines. And then regarding progesterones, now there is a lot of talk has happened for progesterone and their uses. And again, the audience that I'm talking to is very well versed in the use and has got a deep understanding of the type of progesterone they want to use, whether they want to use natural or synthetic in these cases of AUB. But I would go back and take your attention to this chart, which tells us that whatever progesterone we use comes with a derivative of whether it is testosterone derivative or whether it is natural or synthetic. And I really believe that in the light of emerging evidence, it is the responsibility of us as gynecologists to know whether we are prescribing natural progesterone, which encourage the shedding of the uterine lining and are suitable in low hemoglobin patients, or we are prescribing the other synthetic
Yeah,
progesterone.
we have 2 more minutes because I think we are
So the
running out of time.
Okay, so just last slides really. I'm just pointing out to the evidence that has come through, which is pointing to breast cancer and the use of progesterone. The latest article in 2019 suggesting that if you will that the progesterone which are not natural progesterones and actually can cause and are associated with breast cancer. So our women coming at 40 years of age and we are giving them with all this knowledge strong with androgenic activities can be related. The evidence is still not out there, but I think as gynecologists, I would like to highlight this to our group to watch out for the evidence which is coming through. Thank you very much.